This is really to explore whether there's interest in forming a work group or bringing people together on this topic. So I've been long interested in overuse of healthcare or low value healthcare. So my ultimate goal is to be able to generate evidence about the effectiveness of interventions to reduce low value care delivery. So beyond just descriptive, I want to fix things within a learning health system. But most immediately, I want to identify and quantify wasteful practices that harm patients and increase costs, then be able to inform our health system as we work towards value-based care goals and contribute to the learning health system by leveraging our own data to inform evidence-based interventions. So that's my local goal, and I suspect it may be other people's goals as well. So I'm wondering if people would like to participate in developing and refining measures of low value care using EHR data in the CDM, and then hopefully use these measures when conducting scalable, reproducible research to reduce overuse, improve healthcare delivery, and improve patient outcomes. I've been measuring overuse for a long time, but primarily using claims data. I have not used EHR data, and it really requires some different thinking kind of about the denominator. Next slide. So to operationalize these measures of overuse in OMOP, there's really choices that have to be made. If there's an overuse event in this illustration, an MRI of the spine in a patient with new low back pain, right? You're not supposed to do that. What is the denominator? Is it all MRI spine? Is it all patients with new low back pain? Or is it all patients attributed, say, by CMS to Johns Hopkins Medicine? So there's a lot of choices, and we have to realize that we're not seeing the complete information on the patient if they travel across town, but we are responsible for what happens within Johns Hopkins Medicine. So we've started to explore operationalizing, and my colleague Shanshan Lin took some measures to the Odyssey Forum in New Jersey last October. Here's an example: non-selective peripheral alpha-1 blockers. You're not supposed to use those for hypertension control unless the patient has another reason to be on them. That's part of the American Geriatric Society Beers criteria about inappropriate medication use. So we operationalized that. And the next slide. Among other metrics that we have some confidence in and some have less confidence, but for instance, non-selective peripheral alpha-1 blockers are not prevalently used at Johns Hopkins Medicine, just in about 2% of patients across these years. We can also look across individual clinics so that we can provide feedback to individual clinics about use of these inappropriate procedures. Next slide. So I'm inviting everyone to join us to develop a set of measures, rigorously select from among candidate measures, informed by literature review, perhaps by stakeholder input, collaborate with data scientists to operationalize these measures in the CDM, building upon our existing claims-based measures, and we have about 20 or 25 measures in claims already, and explore developing an aggregate measure of low-value care delivery, which is something I had done previously in claims and found it to be really useful. So I'm proposing to form a work group maybe that would meet monthly to advance the use of the CDM and the Odyssey network for learning health system science on this topic. I had posted to the discussion forum several months ago. Didn't get a lot of interest, but maybe now there will be.